本日は、ダッカ日本人会、ダッカ日本商工会主催によります、医療ウェビナーの方にご参加いただきまして、誠にありがとうございます。開始前にですね、注意、事項とお願いを申し上げます。参加中はですね、皆様、音声の方をミュートにしていただきますよう、よろしくお願いをいたします。2点目でございます。本日ですね、Q&A のセッションがございます。もしですね、ご質問をあられる場合ですね、チャットボックスの方に、事前に入れていただいても結構でございますし、Q&A セッションの際にですね、ご質問いただいても結構です。その場合ですね、もし、可能でしたらですね、アシフ先生もしくはイスラム先生にご質問される場合は可能でしたら、英語で、いただけると幸いです。難しい場合は日本語で結構でございます。では、以上が、注意事項になります。もう少々お待ちください。イスラム先生、Thank you very much for joining.
Oh, thank you very much. I'm sorry because maybe I'm being late or it's just.
No, it's okay. Thank you very much. Islam sensei, in your presentation, are you going to share your screen by yourself?
Yeah. I'm sharing from here. Can you check it? If I share, I'll share.
Could you try it now?
Yeah, sure. You can see this one?
দেখা যাচ্ছে, ধন্যবাদ.
দেখা যাচ্ছে, okay.
ধন্যবাদ.
Okay, দেখা যাচ্ছে, okay.
이걸 캔슬 করে দিবেন এখন.
No.
좀 이따가 perfect. Thank you very much.
Okay. Just finished my Shinkate. So it's very tough day because we put stenting in 3 patients.
Thank you very much for.
聞こえますか、先生？聞こえます？
聞こえます。
Okay.
Thank you very much. So could you cancel the screen now?
Yeah, I'm canceling. Yeah.
Thank you very much.
Just stop sharing. いいですね。
Stop sharing で OK です。はい、ありがとうございます。それではですね、定刻になりましたので、ウェビナーの方を始めさせていただきたいと思います。本日はですね、改めまして、ダッカ日本人会、ダッカ日本商工会主催によります、医療ウェビナーの方にですね、ご参加をいただきまして、誠にありがとうございます。私、本日、司会、および進行を務めさせていただきます。ダッカ日本商工会、事務局長をしております、安藤と申します。よろしくお願いをいたします。それでは、開会に先立ちまして、主催者であります、ダッカ日本商工会会頭の河合商工会会頭の方からですね、ご挨拶の方を頂戴をしたいと思います。河合会頭、よろしくお願いします。
はい、ありがとうございます。日本商工会の会頭を務めます丸紅の河合と申します。本日はご参加いただきどうもありがとうございます。また、本日お話ししていただける市川医務官、アシフ先生、イスラム先生、今日は貴重なお話をいただけるということで、本当にありがとうございます。このセミナーなんですけども、ちょうどいいタイミングのセミナーかなと思ってまして、ご存知の通り、バングラの方の感染率は下がってきてて、皆さん、バングラ人も我々も含めて皆さん活動を始めていると思うんですけども、去年も10月、11月ぐらい、若干感染が下がってきて、活動をしていたら、12月ぐらいになって、感染が増えて、いろんなところで感染者が出ると。で、やっぱり感染者が出るといろんなところで大変になるなというのが去年の教訓でして、そういう意味で言ったら、もう一度この、今、落ち着いてと言われている状況の中で、コロナの最新状況のお話を聞いたりと、あと、どういうふうに治療するかっていうのをもう一遍確認したりという話というのは、ものすごい貴重な話かなと思ってますし、またもう1年半コロナと、戦って、自宅隔離とか自宅待機とか、体も心も結構疲れてると思うんで、そういう意味で言ったら、いろんな、他の病気のことについても、イスラム先生からお話しいただけるということで、本当に楽しみにしております。本日は本当に、石川医務官アシフ先生、イスラム先生、本当にどうもありがとうございます。ぜひ貴重な話を聞かせていただきたいと思いますので、よろしくお願いします。
河合会頭、ありがとうございました。そ それでは、本日ですね、日本大使館様からですね、大変なご支援、ご協力をいただいております。続きまして、日本大使館、山谷講師様からですね、ご挨拶の方を頂戴したいと思います。山谷講師、どうぞよろしくお願いをいたします。
はい、安藤さんどうもありがとうございました。日本大使館講師の山谷でございます。本日はこのような場で、ご挨拶させていただきますこと大変光栄に存じます。河合会長をはじめとする日本商工会の皆様方、そして、加納会長様、ダッカ日本人会の方々、深く御礼を申し上げたいと思います。そして、本日お話をいただけるですね、アスガリアリホスピタルのアシフ先生、そしてからエバーケア病院のイスラム先生、我々在留邦人のためにですね、このようなお話をいただくことができまして、心より御礼を申し上げたいと思います。ご参加の皆様、よくご承知のように、これは確か昨年3月8日でしたっけ、当国でも初めての感染が確認されてから、感染状況、それから社会状況というのは目まぐるしく変化をしてきたわけで、当初はこの病原体に対するその病原体学というかパソジェノロジー、それから疫学、エピデミオロジーの関係の知識というのもよく普及することなく、街中にはマスクもせず無防備でいる人がいる一方、恐怖に駆られてパラノイアに陥るような人もいて、そんな中で、どんどん世界がですね、動かなくなってくると、どうなってしまうのかという不安の中で第一波のサージを迎えていたのが、秋には収まって、収まりつつある気配を見せて、活動が再開されるのかなというふうに、思いしや、先ほど河合会長もおっしゃられた通り、また次のサージが始まって、2月にワクチンキャンペーンが始まったはずなんですけど、それにもかかわらずというか、ワクチンキャンペーンが始まっている中でどんどん第2波がサージしていくと、そんな中で、5月以降デルタ株が流入して、この夏にかけての、大流行となったわけですけど、なぜか今収まって、収まってはいないんですけど、収まる方向にどんどん動いていくと。そして世界もそのワクチンの接種率が高まるに向けてですね、ポストコロナに向けて、いろいろな動きがある、社会経済活動を戻していこうという動きがあるんですけれども、でも、実は我々にとってリスクはなくなったというわけではないと。後ほど当館医務官の石川よりも解説あるかと思いますけれども、やはりこのデルタ株の感染力の強さというのは、従来株の常識を超えるようなところもあり、それから当国の状況でも全国の状況収まっても、やはり我々かなりの法人の方々住んでおられるダッカにおいては引き続き高い感染率があると。第3波がいつ来るかと、そういうような懸念予測というのもあるわけで、結局、我々この2つのですね、社会経済活動をどんどん活性化、また復活させていこうという流れの中と、結局、コロナウイルス自体はなくならず、非常に感染力の強い株もあると。言ってみれば、そのウィズコロナをどう生きるかということで、特に生活ビジネスの面で最前線に立つ皆様方はですね、この課題に頭を悩まされておられるんじゃないかと思われます。大使館も同じでございます。我々もこのリスクが非常に高い、リスクがあるという状況は分かりながらも、さまざまなその外交行事、外交活動、それから当国政府の活動とか行事、こういったものにですね、業務として関わっていかざるを得ないということで、どうすればいいのかというのは日々悩んでいるところです。で、結局、そのリスクっていうのを排除するっていうのは分かりやすいんですけど、これは言ってみればノーマンズランドでですね、ずっと自分を隔離していくというのは一番分かりやすいんですけど、実現可能性は多分ほとんどの人にとってはないだろうなと。そうするとやっぱり我々としてはまずリスクをコントロールすると 可能な範囲でコントロールするといっても難しい話ではなくて、いわゆる3密の回避であるとか、マスクとか手洗い、それから万が一に備えてのその体力増進とか健康管理っていうのもある、そういったリスクコントロールというのと、もう一つは不幸にして感染してしまったときにですね、その病状、症例をどうやってマネージするかっていうケースマネジメント、こういったものを組み合わせてですね、生きていくしかないんではないかということで、おそらく皆様はですね、この感染、防止のための措置というのは、引き続きですね、ワクチンを接種した後も取られているかとは思うんですけど、私もワクチン接種した前後で、実はあまりほとんど行動は変わっていません。それと同時に、その感染した時のケースマネジメントとして、じゃあ感染した時どうすればいいのかとかですね、脱下でじゃあどこまで、治療ができるのか、それから他の病気にかかってしまった時にですね、どこでどういうふうに見てもらえるのかと。で、場合によっては、緊急移送の判断とかをしなきゃいけないのかと。こういったところをですね、関心をお持ちなんじゃないかと思われます。一言で言いますと、世界がこういうふうに動く中でですね、このリスクっていうのをどうマネージしながら生活にビジネスに生きていくかというのが、我々、今かなりの人が悩み、そして関心を持っているところじゃないかと思われるところです。その観点から、今回のこのウェビナーですけど、大変タイミングの良い時期に合った企画かと思われます。私、そして大使館からもですね、ましても皆様にはぜひこの機会を生かしてですね、今後のこのリスクが継続する中でですね、我々の活動をどう取り戻していくかというのをですね、考える材料になり、そして在留邦人社会がですね、活性化していくというようにつながって、つながればなというふうに思いますので、その点、今回のウェビナーの開催にご尽力、ご協力いただいた方々に、再び再度心よりの御礼を申し上げて、私のご挨拶と変えさせていただきたいと思います。どうもありがとうございました。
山井講師、ご挨拶頂戴いたしましてありがとうございます。また、日頃からのご支援、いつもありがとうございます。それでは、講演の方に移りたいと存じます。本日お一人目のですね、講演者になります。日本大使館からですね、石川医務官の方からご発表の方をいただきたいと存じます。テーマに関しましては、バングラデシュにおけるコロナウイルスの最新状況でございます。それでは、石川医務官よろしくお願いいたします。
はい。日本大使館の石川です。早速ではございますが、画面の方を共有させていただきます。
見えております。
はい。ですね、私の方からの話題はですね、バングラデシュの新型コロナウイルスの感染状況の最新のものをお伝えしたいと思います。続いて、アシフ先生がこの国での治療法に関してお話ししていただけるということなので、そのちょっとした橋渡しになればと思いまして、日本でどんな治療をしているのか、私自身が日本で治療をしているわけではございませんので、あくまでもガイドラインレベルでのお話になりますが、簡単にご紹介させていただきたいと思います。バングラデシュの感染状況ですけれども、皆さんもご存知の通り、10月9日更新のものをスライドに示しましたが、改善の段階といいますか、改善を続けております。といいますのも、1日の感染者数はですね、500人前後を推移しておりまして、実効再生産数は、これはですね、1人の患者さんがいろいろな対策を講じていても何人の人に移すかということなんですが、この数値が1以下の場合、感染が収束に向かうんですが、幸いにもバングラデシュではですね、2ヶ月にわたって1以下を維持しております。つまり、新規の感染者数は 引き続き減少している状況ということになります。さらに検査陽性率ですが、こちらは 5% 以下が目標となっておりますが、現在の検査陽性率は 2.5% と、形の上ではですね、感染制御ができている状態ということができます。一方、法人の感染者数は計97人ということですが、最近ですね、非常にまばらといいますか、散発にとどまっております。こういったことでですね、非常に、明るい兆しが見えているんですが、少々気になることもございますので、それを皆様に注意喚起させていただければと思います。一つはですね、やはり再拡大の可能性は否定できないということですね。日本を対象とした予測、統計学的な手法を用いた予測では、来年1月以降というような報告もございました。ただ、気候などさまざまな要因が異なるので、バングラデシュでどうなるかに関しては全く不明でございます。ただ、報道等によれば、やはり再拡大はあるのではないかというような意見の方も少なからずいらっしゃるようです。そしてもう一点はですね、当地の法人は、日本における同胞、あるいは当地のバングラデシュに比較して感染率が高い傾向にあります。これは推測でしかないのですが、当地の法人約1000人、これは在留届ベースです。中97人が感染しております。この 9.7% という数はですね、他の数に比べて1桁多い状況です。当然ながら在留届ベースですので、それよりも多いかもしれませんし、また在留届を出していてもいない方もいらっしゃるので、あくまでも推定ではございますが、1桁違うとなるとですね、やはり多いのではないかなと印象を持っております。そして先ほど山谷講師から言及がありましたが、ダッカメトロポリタンの人口当たりの1日感染者数は依然として比較的高水準、比較的ではございますが高水準であるとは言えます。全国の新規陽性者数の 50% を超えている状況というふうになります。これは人口100万人あたりおよそ23人に相当しまして、この数はですね、日本の基準からすると感染者数だけを取ってみるとグレード3の状況になるということで、決してまだ本当に安心できるというわけではございません。では今後の感染拡大を左右する因子を考えた場合ですけれども、これは主に以下の3つ、つまりはワクチンの接種率、変異ウイルスの出現、ロックダウンとさまざまな規制がどのようになるかにかかっているかと思います。ただ、先のことはわからないのですが、過去のことは復習といいますか、レビューすることができますので、一つずつ見てまいりましょう。まず、ワクチンの接種率ですが、2回接種完了者というのはですね、対人口比約 10.65% にしかなっておりません。これは10月9日発表分までですが、しかもですね、2回接種の人の割合を見てみると、右の欄、ここに示しました通りのような状況になっております。モデルナが 13.86%、ファイザーが 0.3%、アストロゼネカ、ゴビシールドが 30.22% で、半数強といいますか、55%、56% をですね、シノファームが占めております。これがですね、どのような影響があるかということに関しては、集団に対しては残念ながら接種率が 10% を超えた程度ですと大きな影響はないのかと思います。ここに感染者の動きを並べてみますと、ちょうどこんなような形になります。この絵を見せるとですね、逆に皆さん誤解を生じるかもしれませんが、今回の第2波が収まると同時にですね、接種率が上がっているのが分かると思います。ただこれはですね、ただの偶然ではないかというふうに考えております。理由は先ほど申し上げた通り、10% 程度ですと集団に対する影響はございません。ただ個人レベルで見た場合、重症化あるいは死亡の阻止とかには十分役立っていると思いますので、もし未接種の方がいれば 最終的には個人の判断で決断していただければよろしいのですが、接種を検討していただければ、大変嬉しいかと思います。続きまして、変異株について、ご説明いたします。これは第2波の感染状況と変異株の検出数等を合わせたグラフになっております。皆さんもすでにご承知かと思いますが、第2波の前半におかれましては、変異株の種類としては、アルファ株とベータ株が主流でした。しかし、第2波の後半におきましては、ほぼほぼデルタ株 100% の状況となりまして、新規の陽性者数、あるいは死亡者数も大きく増加してしまいました。そして、理由はわからないんですけれども、今、感染が収束の方向に向かっているという状況です。そしてですね、バングラデシュでは、デルタ株、非常に猛威を振るったわけなんですけれども、幸いにもこれ以外の変異株に関しては、今のところ検出の報告がありません。ただし、ゲノム解析がですね、システマティックに行われているかどうかに関しては若干の懸念があるので、本当にないのかどうかは分かりません。つまりはですね、件数がそこまで多くはないのです。ただ検出されないだけという可能性もあります。ですが、今のところ変異株の検出はない、感染状況も収まっているということから、比較的嬉しい方向に事態は進んでいると考えます。一方ですね、ロックダウンとの規制の厳しさと陽性者数の動きを見てみます。ここで規制の厳しさを表すのに、厳しさの指標、ストリンジェンシーインデックスというものがございます。こちらはオックスフォード大学で算出されているものですが、教育機関、職場、公共イベント、集会などの閉鎖、禁止、制限などの吸引種を評価して、0から100に直したものです。0がほぼ制限なし、ほぼというか、ほぼ制限がなしですね。100が最も厳しい制限、規制というふうになっております。皆さんもご存知の通り、3月8日第1例が発生してから、徐々にといいますか、比較的急に規制が厳しくなっておりまして、長らく経過しておりました。この規制の厳しさを世界の他の各国と比べてみますと、少なくともですね、政府が出している規制に関して言えば、他の世界の中でもかなり厳しい規制が行われてきた国の一つがバングラデシュとなります。もちろんですね、規制、しっかり行われているかどうかに関しては皆さん様々なご意見があるかと思いますが、形の上と言っては失礼ですが、政府が出している規制に関して言えばかなり厳しい規制が行われていたというような状況になっております。そしてつい最近のことを皆様思い浮かべていただけるとありがたいのですが、このイードの時にですね、規制が緩みました。規制が緩んで、それが終わったら規制を史上最大限まで上げるということで、規制が上がっております。その後から感染が収まっているんですね。したがって、これを見る限り、規制の効果があったように感じるんですけれども、そこは、待て待てという感じになります。つまりですね、規制そのものも感染を見てから決めていますので、この2つが伴って動くのは、ある意味当然ということもあり得ます。ですが、私の印象としては、規制、確かに緩んでいたりすることがございましたが、ある程度、一定程度の効果があったのではないかというふうに感じております。皆さんご存知の通り、個人レベルでの行動規制といいますか、早い話、感染対策ですが、これは、やはり効果があったというふうに、効果があるのではないかと考えていらっしゃる方が多いかと思いますので、ですので、このあたり、規制はですね、集団においても一定効果、個人においては今後も続けていくべき行動かと思われます。ここまでのところをまとめますと、残念ながら未だ学科で人口当たりの感染者数は比較的高水準にとどまっております。ただ、良い話としてはこちらも改善中ということです。 バングラデシュにおいてワクチン接種の効果は接種率の低さから未だ正確な評価はできておりません。しかしながら、このまま接種率が上がれば、他国の例から重症化阻止、死亡率の低下はある程度期待できるのではないでしょうか。デルタ株以来、新規の変異株はバングラデシュでは検出されておりません。感染対策における規制の効果は不完全ではありますが、一定程度の効果は期待できると思っております。少なくとも個人レベルではですね、感染対策を引き続き行うべきと考えております。ぜひともこれを皆様に履行していただきたいと思います。続きまして2つ目の話題ですが、重症度分類とそのマネージメントについてお話しいたします。こちらは主にですね、COVID-19 診療の手引き第5版より情報をいただいて作成しております。マネージメントにおいてはですね、やはりどういう状態において、あるいはどういう時期においてどういうマネージメントを行うかが大切になってきます。まず、暴露前ですが、暴露前に関してはですね、当然これはワクチン接種ということで、医学的なマネージメントを行っていくことになります。その次に、もし暴露して運悪く発症してしまった場合、軽症ということで、最初は軽症ということになるのかもしれませんが、この軽症の分類は、動脈血酸素飽和度が 96% 以下となって、肺炎所見がない人というふうになっております。今までこの軽症に関しては、経過観察と、対処療法がメインだったんですけど、ここに来て、抗体カクテル療法というものが日本でも実施されるようになってきました。現在のところ、モノクローナル抗体カクテル療法、あるいはモノクローナル抗体療法ですが、これは日本においては重症化のリスクがある人を中心に行っている様子です。今後、薬の供給状態とか、非常に高いお薬ですので、その経済学的な面とかを考慮して広がる可能性はありますが、現在のところは少なくとも重症化のリスクがある人に対して、高齢者であるとか、糖尿病を合併しているとか、心疾患、高血圧があるとか、そういう方を中心に行っているということでした。一方、中等症ですが、中等症は、示しました通り、1と2に分かれます。1はですね、93% から 96% の動脈酸素飽和度で、肺炎の所見はあるんですけれども、酸素投与の必要性がないような患者さんのことを言っているということになります。一方、中等症2の方は、93% 以下に動脈血酸素飽和度が下がってしまい、酸素の必要性が生じた方ということになります。こういう方々にどういうマネジメントをしているかといいますと、酸素の投与の必要性がない場合はですね、あってもなんですが、今現在やるのはレムデシビルですね。レムデシビルを使っています。これはもともとは中等症2の方を中心に使っていたのですが、最近お薬の供給状態が改善しているせいもあるのか、医師の判断において中等症1の方にも積極的に使うようになっております。原則5日間、個々の状況によってそれ以上の投与も認められております。さらに、状況によっては、細菌感染が疑われているときは抗菌薬を併用しております。一方、中等症2に至った場合ですね、これは先ほどの定義、酸素投与の必要性がございますので、当然酸素療法を行います。酸素療法は、マスクによって酸素を投与する場合もございますが、人工呼吸器に近いような状態、ハイフローネーザルを用いたりすることもございます。同時にですね、中等症2以降では特にウイルスそのものではなくて、サイトカインストームという免疫学上の基準によって状態が悪化していくということもありまして、それを、改善といいますか、元に戻そうという作用の時に、ステロイド、あるいはインターローキン、拮抗薬等を使う、それがバリシチニブ、あるいはトシリズマブといったものですが、こういったものが中心に使われています。そして、大事なことは、これは抗凝固療法を必ず行うということですね。 合併症として血栓症は皆さんもうご存知、よくご存知かと思いますけれども、この抗凝固療法、ヘパリンなどによって抗凝固療法を行うのが、マストとなっております。一方、重症に至った場合です。通常は、これ ICU に入室するわけですが、基本的にいわゆるコンベンショナルな、人工呼吸器が必要な状態を考えていただければと思います。気管相関と言われる人工呼吸、処置をしまして、人工呼吸器につなぎ、さらにそれでもうまくいかない場合は、膜型人工肺、ECMO の使用が考慮されるというような状況です。レムデシビルに関しては引き続き使われる場合もありますが、必ずしも効果を発揮するというわけではないようです。ステロイド、バリシチニムに関して、あるいは抗凝固療法に関しては引き続き使います。さらに、抗菌薬に関して人工呼吸が必要な状況では、ほぼ 100% 併用されていると思われます。さらにですね、ここに来て、最近報道を賑わしているのは、経口の治療薬、あるいは予防薬といったものが出てきたというような状況です。この経口の治療薬、あるいは予防薬は、軽症の患者さん、あるいはまだ臨床治験段階ですけれども、濃厚接触者などの発症前に関しても使用するということが期待されております。どのようなものがあるかというのをスライドにしました。皆さんもよく名前を聞くのはモルヌピラビル。これはメルクで作っているものですけれども、ウイルスの RNA の複製を阻害するものです。効果の率は 48% というふうになっておりますが、これは比較的重症化リスクの高い患者さんを中心にやっておりますので、かなりいい成績なのではないかというふうにも言われております。すでに3層試験が終了して実用化に突き進んでいる状態ということになります。インドの製薬会社でもライセンス生産を予定しているのですが、ほんの数日前、昨日、今日だったと思うんですが、インドでの治験が中止という方が入ってきました。どうやらこのモルヌピラビルは、軽症の段階では効果があるんですが、中等症の患者さんにはあまり目立った効果がないというところが今のところの評価のようです。さらにファイザーはウイルスのタンパク質を合成を阻害するという基準に基づいて、臨床試験では濃厚接触者に対して使われて、発症予防がどうなるか、ということを治験で、確認している段階となっております。現在、2層、3層が行われているわけですが、このようなお薬が、実用化されたならば、新型コロナウイルス感染症に対して非常に明るい兆しになるのではないかと思われます。さらに、塩野義であるとか、中外製薬であるとか、日本の製薬会社も関与している抗ウイルス薬が、今、治験段階になっているということです。そして最後の、これはおまけみたいなものですけれども、当地でも問題となっているデングウイルス、ジカウイルス、あるいは日本脳炎ウイルスなどに対しても有効であるコロナウイルス治療薬が北大を中心に開発されております。これはまだ実験段階なので、経口薬として出てくるのかどうかすら分かりませんが、一つ非常に明るい話題なので、あえてここに載せていただきました。以上ですね。これからコロナのマネジメントですけれども、ワクチンの接種に加えて、抗ウイルスモノクローラル抗体療法、あるいは経口コロナ予防薬、治療薬の出現で、重症化、死亡のリスクが減ると期待されております。ですので、暗い話題だけではないのですが、このような明るい話題も出てきたというのが現況のようです。以上、私の発表を終了させていただきます。
石川医務官、ご発表いただきましてありがとうございました。大変豊富なデータからですね、また日本での治療法も含め、大変貴重な情報をいただきまして、誠にありがとうございます。引き続きよろしくお願いをいたします。それでは、本日お二人目の講演者ご発表に移ってまいりたいと思います。 本日ですね、お二人目の発表者でございますが、日本人の方々がたくさんお世話になっております、山形ダッカ友好総合病院のですね、アシフ先生からご発表の方をいただきたいと思います。発表トピックに関しましては、バングラデシュで受けられるコロナの治療についてでございます。本日、アシフ先生のプレゼンテーションですね、簡単な英語の方でさせていただきたいと思っております。どうぞよろしくお願いをいたします。So, we would like to request Ashif Sensei to make a presentation. You have 20 minutes for your presentation. So, thank you very much, Ashif Sensei. It's over to you.
Thank you very much. Let me share my screen. Is it visible?
Yes, visible. Thank you very much.
Okay. So I start my presentation. I'm very with my, first of all, I apologize for my Japanese has become very worse and I cannot speak very fluently in Japanese. So I will be using English. I will try to highlight some points in Japanese thanks to Ando-san. So as you know that I'm very, at the outset, I'm very grateful to the organizers, the Shu Kokai and the Japanese Association in Dhaka for kindly inviting me to speak at this important webinar on the COVID-19 pandemic. I'd like to express my profound gratitude to Ando-san for kindly providing Japanese translation of some important slides and improve the communication, as well as to Ishikawa Sensei for technical review and valuable advice regarding my presentation. At Yamagata Dhaka Friendship General Hospital, we had the opportunity of serving many Japanese patients with COVID-19 over the last 18 months. And we believe that we are greatly encouraged by this demonstration of trust in our organization and on our professional staff. So with this, I begin my presentation. As you see, I will be covering the following points: the rationale for home and outpatient management, the initial evaluation and referral criteria for outpatient and home management, how do we do the risk stratification, the grades of dyspnea, Kokyu Konnan, that is very important in a COVID patient, the oxygen assessment, and also another critical factor, the assessment of the acuity level of the patient, what are the cautions we exercise during home management, and the home remedies, and a snapshot of the hospital treatment that is provided for moderate and severe patients in Bangladesh. And finally, we will touch on the combination monoclonal antibody therapy, which has already been introduced to you by Ishikawa Sensei in the preceding presentation. So first of all, the rationale for outpatient management remote care. As you know, approximately 80% of the patients have mild illness. So it is very useful, it is very rational that they will be treated at home. Moreover, staying at home prevents the transmission of SARS-CoV. So that also itself is an opportunity of isolation, cuts down the chain of transmission. But nevertheless, we ought to have a coordinated care management program in which how we have to initially have a risk stratification of the patient. Then again, the patient should be connected to a dedicated outpatient respiratory clinic. There is also a good, have to have a close relationship with hospital if there is any sudden deterioration. And also there should be opportunity of telehealth visits by telephone call or video platform based.
I think, excuse me, the slide has not changed, I think, for some technical issues.
Oh, really?
Yeah, you have still the second page outline. So
I'm still outlined. Here it is changing. Yeah. I'm sorry. Let me again come back. Okay.
I think some technical trouble. Okay. Yeah. We can now visible. Yes.
Yes. Now we're okay.
Now okay. Thank you very much.
Thank you. So as I said that Shoki Hyoka, at the very beginning, we have to have a good initial evaluation. And what do we assess? The risk factors for severe disease, dyspnea severity, which in Nihongo I will try in my difficult Japanese. Jushokan no risk hyoka and Kokyu Konnan no level to kikan, dono gurai natteru ka, sore o kangaemasu. それから呼吸困難と酸素のレベルを考えます。もちろん、the overall acuity of the patient and the patient's home setting. These are the things we need to study before we decide on the management of the patient. And the referral criteria for hospitalization, Nyuin no Sanko Kijun. So in here, we are talking about the Kokyu Konnan, which is しっかり話せないこと人はもちろん 非常に呼吸困難に当たっている。オキシジェンサチュレーションレベルは 90% 以上だったら、それも大変なことです。それから意識の変化、それから低酸素の症状、like hypertension、めまい、それから胸の痛み、and definite 急臭の悪化、例えば糖尿病か、アズマか、ハイパーテンションの悪化すれば、それはホスピタライゼーション入院にすることです。There are some red flag symptoms, for example, severe breathlessness or difficulty in breathing, or a pain and pressure in the chest, blue lips or face, which anybody accompanying person can identify. Then again, suddenly the patient is having cold and clammy skin, is becoming confused, difficult to rouse, or there is urine output is reduced, or in some cases, suddenly there is bleeding from the mouth that requires urgent hospital transfer. So if we don't have this kind of situation, then we can refer the patient to the outpatient clinic, where one of the more following features, if he has a very mild kokyu konnan and his oxygen saturation is between 91 to 94% on room air without any oxygen, or he has a mild respiratory problem, in that case, we can refer the patient to the outpatient clinic. And those who do not fall in this criteria, neither hospitalization, neither outpatient clinic, they can stay at home and continue the home management with a linkage to the health service. Now, the risk stratification is very important. So I would like to speak here in Japanese or point out the Jusho no Jinri. What are the factors we consider as high risk? One is Nenrei ga 65歳以上だったら、それから糖尿病、面会の不全の状態、喘息か COPD 受けている人、それから循環器病、肥満, that is a very obese patient, body mass index is more than 40. Then we have Jinzo Shikan, kidney disease. It can be no Kekkan bio, cerebrovascular disease, history of stroke, or it could be Kanzo Shikan, which is a chronic liver disease. And finally, very important, it could be somebody who is using tobacco regularly. So these are the high risk situations. In the moderate risk, we consider the young patients, the age is between 20 to 64, with none of the comorbidities. And if it's less than 20 with a comorbidity like asthma, that is also a moderate risk patient. Whereas age below 20 years, no underlying medical conditions, is a very low risk patient. Now, this is very important, the grades of dyspnea, that is Kokyu Konnan no grade. Ichiban wa, this is the mild dyspnea, that is where the respiratory problem, Kokyu Konnan wa jibon no daily activities has no interference or impact. In the moderate dyspnea, the patient is having limitations to activities of daily living, for example, meal preparation or his or her light housekeeping tasks. Whereas in the severe dyspnea, it causes shortness of breath at the rest. As I said, that shikkari hanasenai, he or she cannot talk properly, or it is interfering with the basic activities such as toileting and dressing. So this is called severe dyspnea or kokyu konnan. And we also look at the acuity level of the patient, not only the respiratory situation, not only the oxygenation, but also what is the patient doing? Is he feeling dizzy? Is there any history of falling down? Is the urine output normal? Was the patient having any chest pain, any confusion? He or she cannot talk properly, or the blood pressure has gone down. This kind of situation also calls for hospitalization. Sorry. So when we do the oxygen assessment, we are very familiar with the pulse oximeter nowadays. So they use the pulse oximeter is very important. It should be done on the warm fingers. If you come from shower and immediately use this, then it may give a wrong reading. And usually at the home management, it is suggested to do it thrice daily and inform the clinician, his attending doctor, if it is below 95%. Also, when we use the pulse oximeter, we should keep our hands very relaxed and we should give some time. Instantly after putting, we should give at least 30 seconds to 1 minute, 60 seconds before we make a final decision of what the saturation is. So these points please bear in mind. Note of caution, very important. A normal oxygen saturation level does not exclude clinically significant respiratory involvement. So this is a term used by the British doctors. They have introduced happy hypoxemia. Patient is having low oxygen, but he is very happy and comfortable. So it should, although we should be very careful that the normal oxygen level is reassuring, but there is no guarantee that the respiratory status will not deteriorate with progression of illness. So if a patient or some person is not feeling well, although the saturation is fine, they should have a consultation with doctor, as I have shown you a long list of problems which can happen also without relation to the respiratory system. The kokyu naika igai mo ippai mondai ga aru. So some tips for patients who are taking the home oxygen, that is some information. One, they should contact the doctor if the oxygen saturation levels are declining on an established flow rate. He is taking 1 to 2 liters, but suddenly saturation is going down. Oxygen saturation drops below 91%. Kyuju ichi ika sanso level itte shimau. Korekara the kokyu konnan, the dyspnea is worsening, akka shitemasu. Even then, so this is very important to contact the doctor. I will just use this slide to impress to you that what are the other systems which are involved in the COVID-19. We know we are focusing on the respiratory system, but here we can have heart disease, we can have digestive problem, we can have acute kidney injury, there can be immune hematological issues like the shock. There is a psychological element which is called the brain fog. There is neurological element which is called the post-COVID stroke. And also in the long run, there is an effect on the reproductive system. So COVID now is, even if we overcome the initial stage, the extra pulmonary complications, we call it a systemic disease. So it is practically a Pandora's box, you can say, when a patient is recovering from COVID. Now, so what do we do when for the counseling and management of the patient? We are using the treatment regimen as per the guidelines. The Bangladesh government, the Director General Health, has published the latest, the 6th version of the guidelines. It is an updated document. And we also, I'm a pulmonologist. My specialty is Kokyu Naika. So we are managing the Bangladesh Lung Foundation, and our senior people are also issuing some position statements. So with that, we are providing the best service possible to the patients in Bangladesh. The symptom management is very easy, as you can see, and continue the other treatment. This, I would like to draw your attention that there are some warning symptoms like the kokyu konnan, which is suddenly coming. I was well, the patient was well yesterday, suddenly today he's feeling very severe onset, or the dyspnea he had level yesterday is suddenly deteriorating. It could be a heart attack. If he's feeling dizzy, then also there is some problem with his blood circulation, and also mental status changes such as confusion. Well, we are talking of the best case scenario where the patient is taking rest at home with the symptomatic treatment and some home remedies. We are talking about zinc supplement, vitamin C, vitamin D, and high potency. Traditionally in Bangladesh, turmeric and ginger has always been part of our natural medicine alternative for hundreds of years. And hot tea with lemon and ginger, I think Japanese people also enjoy this. And this is becoming very popular as a home remedy in COVID-19. Now, on advice of Dr. Ishikawa, I have included this slide to give you an overview, just a snapshot. I will not go into the details, but as you can see in Bangladesh, we employ the antivirals, the remdesivir, in the intravenous injectable form, Chusha, and Nomigusuri is favipiravir, which was originated in Japan as an antiviral drug, and we are using it to good results. We also have antibiotics for the outpatient departments, oral azithromycin or doxycycline. In inpatient department, we are using Tenteki intravenous antibiotics of different types. Coming to the steroids, which Dr. Ishikawa mentioned, the dexamethasone is the most popular. It has had a trial, and prednisolone and methylprednisolone and some other drugs. Dr. Ishikawa also talks about baricitinib. It is available in Bangladesh. We are using it for the moderate and severe patients, and in case of critically ill patients, we are using tocilizumab, although now the supply is a bit short, but nevertheless it is helpful. I myself am a COVID survivor, and I received tocilizumab in last December, and it helped me a lot to recover from my severe state. Also, anticoagulants are there, and the supportive medications back to vitamins, zinc, etomidate, analgesics, and the GI system is irritated, so there is a lot of acid formation, and we use the proton pump inhibitors to handle that acid. So, ladies and gentlemen, I'm coming to the last section of my presentation, which is on the monoclonal antibody therapy, COVID-19 combination monoclonal antibody therapy, Casirivimab and Imdevimab. This is available at limited centers in Bangladesh now. We have used it on a good number of patients. I personally have experience using that, and we are expecting that the supply will be increased. And I will not go into details of the mechanism of action, just to point out that a combination of two recombinant human antibodies in this cocktail, and this therapy represents a higher resistance barrier, this antibody. And as you know that it has been key emerging variants, the recent ones that we know creating havoc, UK, South Africa, Brazil, and all other variants, it can have effective protection against that. So what kind of patients are focused for this kind of antibody therapy? Patients who have confirmed COVID-19, patients who do adult and pediatric patients above 12 years, of course, they are in a mild form of disease. They do not require supplemental oxygen. In addition, they are at high risk of progression to severe disease. As I said before, that the risk factors, maybe advanced age, obesity, cardiovascular diseases, asthma, diabetes, chronic kidney disease, liver disease, or if they have received some cancer treatment, if they are suffering from HIV or immune weakening medications. This kind of patients can receive this antibody cocktail. And what is the result so far? Oh, I'm sorry. Yeah, is the screen visible? Yes.
Yes, visible.
Okay, thank you. So in a high-risk ambulatory patients, the cocktail led to significant improvements in all clinical endpoints, like the reduced risk of hospitalization, reduced duration of symptoms, and significantly reduced viral load. And the dose was almost the same, and it is generally well tolerated with no new side effects. And also, it is interesting that it can be used for post-exposure prophylaxis. If somebody is accidentally exposed to a COVID patient, for example, the household contacts, it reduced the risk of symptomatic infection by 81%. And then in asymptomatic patients who are infected at baseline, like we use the word preemptive treatment, it reduced the overall risk of progressing to symptomatic COVID by 31%. So it is generally well tolerated. It leads to a shorter symptom duration. And finally, it may also help to prevent infection and development of serious disease. There are some Fukusayo selected adverse reactions. One is in any drug, you can have an hypersensitivity, including anaphylaxis and infusion-related reactions. That is when the Tenteki, the infusion is running. So you have to take it in a hospital setting. And there are some other symptoms also, but with prompt management, involvement of the doctor, all events have resolved. So far, this is our experience. This brings me to the end of my presentation. Go Seicho, arigato gozaimashita. Thank you very much.
大変貴重なプレゼンテーションをいただきましてありがとうございます。Thank you very much for your great presentation. Yeah, we thank you for your very important information. Thank you very much. ありがとうございます。それでは、続きまして、3人目のご発表に進んでまいりたいと思います。3人目のですね、ご発表は、エバーケアホスピタルのイスラム先生でございます。トピックにつきましては、パンデミック下の高血圧、心臓発作とコレステロールでございます。So I would like to move to the next presentation. I would like to request Dr. Islam from Ebarcare Hospital to make a presentation. The presentation topic is high blood pressure, cardiac episode, and cholesterol under pandemic situation. So Islam Sensei, please, it's over to you. Islam Sensei, could you unmute yourself?
So, yeah. 聞こえます。Do you hear me? Okay. Thank you very much for giving me an opportunity to speak something in front of you, the learned audiences. はじめましてよろしくお願いいたします。私、日本で平成2年から8年まで勉強されてから阪大から博士を取られて平成8年にバングラデシュへ戻ってきまして、今までエバーケア病院で循環器という専門で仕事をしております。And today, what I want to say, my Dr. Asif Sensei already spoken much of my presentation, so and it makes me more easy for me. And makes my word more presentation more easy. So my topic is high blood pressure, cardiac episodes, and cholesterol under pandemic situation. So as we all knew that we are passing a very tough time for last 1 year and a half, 1.5 year, more than half, and we came across all of the things and many of us already got vaccination and those who got vaccine are a very fortunate person. So this slide shows the COVID, how it gets into the body, and it's a receptor, it's getting into the lungs, haijo nakani. AC receptor ni it's a big attached, and then it produces its effects on kidney, jinjo, shinjo, and then brain, and also in blood vessel as well. And this slide shows the symptoms. Fever is more 88.7%, then seki ga 57.6%, then dyspnea 45.6%, anosmia 33.9%, myalgia, fatigue 29.4%, and sputum production 28.5%, and diarrhea 6.1%. And ARDs が非常に高いな、その中で32.8%, thromboembolic events が 20%, acute cardiac injury 13%. In acute cardiac injury, we got many of the patients came to us with acute myocardial infarction or heart attack, shinjo hosha, what you are saying, and some of the patients is having myocarditis, and then also some comes with COVID injury in a hospital and shock 6.2%, and secondary infection as well. And this slide shows the comorbidities associated with high risk severe COVID-19, GAN, then Jinjono Bioki, then lungs, haijo, then dementia or neurological conditions, Tonio type 1, type 2, then Down syndrome, heart conditions, HIV infection, immunocompromised state, liver disease, overweight and obesity, pregnancy, sickle cell disease or thalassemia, smoking, current or former, solid organ or blood stem cell transplant, stroke or cerebrovascular disease, substances use abuses or substances use disorder, addiction people's. And with these comorbidities, the patients are having more complications with complication and getting into the hospital. And we all knew that hypertension, koketsusu, is a leading risk factor for death and disability. And this slide shows hypertension before COVID, and it says it has been said that by Nissen Niju Gonen, 1.5 billion people will be suffering from HTN worldwide. 30 to 45% people worldwide suffer from HTN and hypertension, with more than 60% people with more than 60 years of age. Almost 10 million deaths each year and 4.55 million deaths in the latest pandemic. 10 milligram, therefore, 10 milligram saga arebas, systolic blood pressure toka, 5 millimeter mercury saga diastolic blood pressure associated with significant reductions in all major cardiovascular events by 20%, all-cause mortality by 10 to 15%, stroke by 35%, and coronary events by 20%, and heart failure by 40%. So this last line is giving you us the real picture that if we are reducing 5 millimeter mercury diastolic blood pressure or 10 millimeter mercury reduction in systolic blood pressure, every patient will be benefited from many of the organs from its harmful effects. Hypertension is the single largest global contributors to disability adjusted life years loss. Majority of the population aged over 60 years of age have hypertension, and it has been suggested that they may be at increased risk from the effects of COVID. And link between hypertension and COVID-19 severity. It's in cellular level, the mechanism that links pre-existing hypertension and COVID-19 are yet to be fully elucidated, but it could be related to endothelial dysfunction, renal angiotensin system imbalance, the conventional renal angiotensin system, that is ACE or angiotensin 2 or AT1 receptor axis activation in parallel with non-conventional ACE2, angiotensin 1 to 7, and mass axis down regulation was proposed to be the underlying factors leading to severe COVID-19 outcome in hypertension. Impact of COVID-19 on hypertension management. This is, we all knew that during COVID times, many of the patients are not coming to regular clinics and not being admitted in regular inpatients because of the fear of many of the patients to come to the hospital. So hospital is full of COVID patients in the city and most of the places. So modifications of physical activity, dietary patterns, alcohol consumption, potential increase in body weight, smoking, emotional or psychological stress, changes in sleep patterns, and diurnal rhythms may thus increase blood pressure and promote poor BP control in treated hypertensive patients. Physician attitude and healthcare related factors associated with delayed diagnosis and increased therapeutic inertia during the COVID-19. Challenges in hypertension management in COVID era, healthcare system, diversion of finances to fund COVID-19 response, disruption of medical supply chains, cancellation of clinics during local lockdowns, social distancing protocol limiting access to care. In general, high blood pressure symptoms, people typically do not know it until their blood pressure is measured. Sometimes have the following symptoms: dizziness, blurred vision, and then nausea as well. And in classification of blood pressure, now it's being said that the current guidelines, blood pressure systolic is less than 120 and less than 80 is normal. So elevated is hyaku-niju kara hyaku-niju-kyu, to less than hachiju. Then high blood pressure is stage 1, hyaku-sanju to kara hyaku-sanju-kyu made systolic blood pressure to diastolic blood pressure hachiju kara hachiju-kyu. And high blood pressure is stage 2 is 140 or higher and 90 or higher in diastolic blood pressure. Hypertensive crisis higher than systolic blood pressure more than 180 or diastolic blood pressure more than 120. And in 90% cases, primary hypertension or essential hypertension is there, and 10% secondary hypertension, and causes are chronic kidney disease, Jinjono Byokitoka, tumors, then coarctation of the aorta, pregnancy, use of birth control pills, alcohol addiction, and thyroid dysfunction. And these are the factors cannot be changed: age, race, socioeconomic status, family history or heredity, and sex, male or female. And factors that can be changed is overweight, obesity, himansha, then sodium salt in sensitivity, alcohol use, birth control pills, lack of exercise, drugs like amphetamines or diet pills. Obese people are 2 to 6 times prone to develop high blood pressure. And some tests we recommend usually as routine test, electrolytes, blood urea, creatinine, and special tests, some of the hormones of adrenal glands, serum cortisol level we can advise. Urine test also electrolytes and serum urinary cortisol level. Ultrasound, kidneys, we can see the renal artery, if there is a renal artery stenosis, and CT scan of the abdomen in any kidney adrenal gland tumor or kidney tumor is there. And this is picture shows the ECG and echo. So proportion of deaths attributes to leading risk factors worldwide is, among all these, high blood pressure is the leading cause of death in the world. And organ damage, it affects most of the organs, especially in the cerebrovascular disease, transient ischemic attacks, ischemic or hemorrhagic stroke, then vascular dementia, hypertensive retinopathy or left ventricular dysfunction, and coronary artery disease, myocardial infarction, angina pectoris, congestive heart failure, and then chronic kidney disease, hypertensive nephropathy, GFR less than 60 per 60, albuminuria, end-stage renal disease or dialysis, and peripheral artery disease, intermittent claudication. And high blood pressure as a cardiovascular risk factor, systolic blood pressure more than 115 millimeter may cause overall 50% of heart and stroke, and 60 to 70% of strokes. Hypertension more than 140 by 90 millimeter mercury causes heart failure 50%, heart attack 25%, and kidney failure 20%. Lifestyle risk factors for hypertension: high dietary salt intake, obesity, high alcohol intake, physical inactivity, smoking, inadequate vegetables and fruits intake, and inadequate milk products intake. In summary, hypertension is a leading risk factor for death and disability. Hypertension is a major cardiovascular risk factor. Hypertension is very prevalent and has a large impact on healthcare resource uses, and lifestyle factors influence blood pressure, including dietary salt. And the obesity also having impacts on, as we know that Nizogata Himan is very much correlated with many of the diseases like hypertension, diabetes, high LDL cholesterol, high triglycerides, and low LDL cholesterol, HDL cholesterol level. And so what happens in COVID patients, obese patients usually having their less immune dysfunction might be there, and also cardiac metabolic diseases, pulmonary function also there is a decrease. Already Dr. Asif briefed about his specialty on pulmonary function and heart disease. There is heart failure with preserved ejection fraction, cardiomyopathy, and increased risk of atrial fibrillation. And kidney produce there is hypertrophy or dysfunction, then endothelitis and hypercoagulability and inflammatory changes is there. Death rate by comorbidities, no pre-existing is 0.9%, cardiovascular disease is 13.2%, diabetes 9.2%, chronic respiratory disease 8%, hypertension 8.4%, and cancer 7.6%. COVID-19 deaths by age and pre-existing conditions, 47.71% is above 75 years, and 65 to 74 years is having 75.8% 58%, and 84.95% is 23.12% is pause between 45 to 65 years. And this is a study from UK published in the journal, and it shows that they have studied diabetic patients about, this is the data from National Health Services in UK, and age and COVID-19 mortality metrics. Age is 0 to 19 is 18, and 20 to 39.7%, and 40 to 59 is 7.8%. And 60 to 79 is 38.1%, 80 plus is 53.3%. Type 1, type 2 diabetes and COVID-19 related mortality in England, a whole population study. People with diabetes in England is 5.16%. I think this is more in Japan and Bangladesh. Percentage of diabetes is more than UK. And in COVID-19 deaths in diabetic patients, no diabetes 94.84%, type 1.43%, type 2 diabetes 4.66%, and other diabetes 0.07%. And people with diabetes in England is 5.16%. So 1/3 of the COVID-19 deaths in hospital in people with diabetes is 33.2%. So this is a really kanari okina kazo nan desu kedo, 1/3. So what practical advice should we give to the majority of people with type 2 diabetes? People with diabetes should be reminded that diabetes increases risk of many infections, and that may include COVID-19. Maintaining good glucose control, a healthy diet, and regular exercise are important for all. Current UK advice is to continue usual glucose lowering drugs and aim to optimize glucose control. Antihypertensives including ACE and ARBs and lipid lowering drugs should also be continued. And COVID-19 diabetes, dexamethasone in COVID-19 patients, implications and guidance for the management of blood glucose in people with and without diabetes. Glucose monitoring target glucose is 6 to 10 millimole per liter. Frequency of monitoring people not known to have diabetes, check the glucose at least 6 hourly, ideally at fasting periods. And after 48 hours, all fasting glucose results are less than 10. Reduce frequency to once daily at evening 17 hours to 18 hours. Continue until dexamethasone is stopped. If any fasting glucose is above 10, and then continue 6 hourly monitoring and follow the guidance below to correct hyperglycemia, that is glucose above 12. People with diabetes throughout the admission check fasting glucose at least 6 hourly or more frequently if the glucose is outside and the 6 to 10 millimole per liter range. Dexamethasone in the COVID-19 patients, managing dexamethasone related hyperglycemia, first exclude diabetic ketoacidosis and hyperglycemia, hyperosmolar syndrome by checking blood glucose, ketones, venous pH, bicarbonate, urine and electrolytes, and if DK or MS diagnosed, follow specific guidelines for their management. And insulin, follow the weight-based tables below in those people not known to have diabetes with type 2 diabetes treated with diet alone or with oral hypoglycemic agents. Insulin treated where the total daily dose of insulin is known, follow the guidelines in the table based on total daily dose. So this slide shows if we reduce the hemoglobin A1C 1%, then we can see the total other complications by, amputation of or fatal peripheral blood vessel disease 43%, microvascular complications, especially in kidneys 37%, death-related diabetes 21%, heart attack 14%, and stroke 12%. So it is quite a significant benefit can be achieved. Specific consideration for primary care management of people with COVID-19 and suspected COVID-19 infections. Most people, 80% will have mild disease and can be managed at home. Usual sick day rules apply. Stop SGL2 inhibitor and metformin if unwell and not eating or drinking normally. Other medication, sulfonylureas, may need adjustment. Never stop insulin. Monitor glucose frequently every 2 to 4 hours. Ketone testing needed for type 1 diabetes. Now I'll talk something about my specialty. This is the classic picture of if a patient is having a heart attack. Then they represented like this, male and female both. And coronary artery disease risk factors, fixed risk factor, these cannot be changed. Male more than 40 to 50 and female more than 45 years after age, that is after the onset of menopause. Male sex are more susceptible. Family history, positive family history, there is a and also LDL receptor abnormality. And the factors that can be changed, like modifiable factors: smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, obesity, especially visceral fat obesity or Nijogata Himansha, and diet rich in saturated fat. And these are the risk factors, what I said already: smoking, high cholesterol, obesity, physical activity, and diabetes. And it affects coronary artery disease, then aorta, then heart failure, that is a Shinjo Sen, and then pericarditis, cardiomyopathy, heart valve disease, arrhythmias, and peripheral vascular diseases. And this is a schematic presentation from American Heart Association. Even though we are saying that central chest pain, but this graph shows a different presentation in male and female, but usually the patient, in whether male or female, having typical classic pain, central chest pain, radiation to neck, lower jaws, and then comes to left hand. And few percent of patients having pain in upper abdomen and then goes back to and settle into the back. And many of the patients who is having acid reflux or gastric pain, study has shown that 1/3 of the acid reflux or gastric pain, if we do the ECG, then we found that 1/3 patient is having a heart attack. So if any patient is having pain in abdomen, I think it's better to have an ECG, and that saves a life. And this picture shows how cholesterol deposited inside beneath the endothelium, and then it ruptured and causes heart attack. And this is the procedure we do, ballooning and then putting stents. So heart attack, severe crushing retroesternal chest discomfort with radiation to jaws and left arm, neck, and back. Elderly and diabetic patient may present as silent MI, not relieved by rest or sublingual GT and spray. Autonomic disturbances like pallor, sweating, brady, or tachycardia may present as shock with hypotension, cardiac failure, and mitral regurgitation. And once the patient comes to us with a heart attack, we used to do, that is what you say, Kyuseishin Kinkoshoku Ukeru Toki wa, what we do, the Shinkate Ushite, we open the clogged artery, and then we are using, nowadays we are using hand mostly, and then this is the blocked artery, clogged artery, and then after putting stents, flow reestablished. The stents are like this. So these are the cholesterol plaque. Then we put stents mounted over a balloon, and then it will remain as a body part, and blood will flow and reestablish the flow. So within 90 minutes of heart attack, if patients come, then the patient's heart muscle can be prevented from any damage, and patient will benefit more. So in our center, we are open for 24 hours and every day, even in Friday as well, for every heart attack patients, and doing this primary PCI. And this shows the bypass surgery, how it is being done. And these are the bypass graft. It's open chest, and surgeons are doing these jobs. Reperfusion of STEMI in COVID-19 era. So in COVID, the procedure has been changed. Primary PCI replaces to fibrinolytic therapy, that is blood thinner is given, and then patients once COVID test come, maybe within next 6 to 24 hours, can be taken to cath lab, and we do the Shinkate, and then we diagnose and treat accordingly. And currently, US practice 13% of all STEMI. STEMI means heart attack. Patients receive pharmacoinvasive therapy, which includes drip and ship approach fibrinolytic therapy, followed by transfer to PCI center for coronary angiography, and PCI within 6 to 24 hours, as I said already. Primary PCI in the UK, USA, or Western world, I think in Japan also, is having a dedicated cath lab. They have separate building blocks, so they can take patients over there and do the angiogram and do the primary PCI and open the clogged artery, reestablish the flow, and patients remain in COVID ward separately. But in our country and those of the center, none of the center in Bangladesh is having COVID dedicated cath lab facilities. So pharmacoinvasive therapy is the ideal guideline treatment that is available in Bangladesh, including in our center. Many of the centers are doing at present. PCI remains the standard of care STEMI patients at PCI capable hospital, as I said, when it can be provided in a timely fashion with an expert care team outfitted with personal protection equipment and in a dedicated cardiac catheterization laboratory. So keeping in mind that patients should not be go for primary PCI if any hospital is not having dedicated COVID facilities or a separate building block where the only COVID positive patients will remain. If anybody is doing apart from this, then it's a crime. It's a means spreading disease and affecting the other peoples as well who are not COVID positive. So acute ST elevated myocardial infarction on top of COVID-19 is very complex situation as we are dealing in our daily routine practice, including our center, Evercare Hospital in Dhaka. Primary PCI has replaced pharmacoinvasive therapy. Patient admit in gray zone in our CCU, and we break the clogged blood inside the coronary artery by tenecteplase, and we do the COVID RT-PCR, and if negative, shifted to main CCU in our hospital as well. And subsequently, we do the coronary angiogram, then cutaneous coronary intervention, putting stents, or if CABG recommended. COVID positive patients after thrombolysis kept in COVID dedicated ward and managed accordingly in a COVID dedicated cath lab. Primary PCI recommended by ACC and ESC guidelines. These 7 things I just want to mention for healthy heart, healthy life. Never smoke or quit more than a year ago. Having a body mass index less than 25 kg per square meter, then exercising at a moderate level for at least 150 minutes or at an intense level for 75 minutes per week. Meeting the key components of a healthy diet, having a total cholesterol of less than 200 milligram per deciliter, and LDL cholesterol should be below 70 for coronary disease patients or patients with heart attack. Blood pressure below, it should be 120/80 millimeter of mercury, and fasting glucose below 100 milligram per deciliter. And physical activity, what does it or how does it help? It reduces total cholesterol, that is bad cholesterol as well, and raises the good cholesterol. American Heart Association or AHA recommends at least 30 minutes of exercise every other day for cardiovascular fitness. House cleaning or playing golf or baseball. Playing golf is very famous among the Japanese, and baseball as well can burn as many as 300 calories per hour. Brisk walking at 3.5 mile per hour, cycling at 5.5 mile per hour, gardening, jogging, or running, whatever we can do for our betterment and keep our heart healthy. Also taking healthy foods like choose foods high in starch and fiber, try fruits, vegetables, whole grain cereals, pasta, rice, and dry peas and beans. Limit serving size, high calorie foods such as meats and cheeses, and try to avoid the temptation of going back for seconds. Write down what you eat and when. Replace high calorie, high fat snacks with fresh fruits or take cereal along to eat at work. Physical exercise can also lower blood pressure, reduces your risk of heart disease, and reduce levels of LDL bad cholesterol, which can clog the arteries and cause heart attack. At the same time, exercise can raise levels of high density lipoprotein or good cholesterol, which helps protect against heart attack by carrying fatty deposits out of the arteries. And one thing I suggest to walk in the evening before dinner, because what happened in the nighttime, we are going for rest. And so if we burn some or lose some fat by evening walk, then after taking dinner, it cannot be oversaturated in the body. So the chances of deposition in beneath the endothelium is very less. And quitting smoking, a healthy diet, and exercise may reduce your risks of heart disease. And this is another few. Almost I'm finishing. So we all knew how to save us and protect us and protect our colleagues and our dear and nearest one. So safety and healthy awareness works, and then clean hand. Then this is the way. Uses of mask. Respirators are needed when there is a potential for aerosol transmission. N95 respirator is the minimum level of protection to prevent inhaling coronavirus. So in our hospital, we are using mostly we are using N95. And surgical masks are not respirators. This should be keep in mind. Surgical masks do not fit tightly against the skin to form a seal, filter tiny particles such as viruses or bacteria that are in the air. And regarding, it's better to use mask only one mask once, and should not touch inside. If anybody mistakenly touches inside, then it should be replaced by a new one. So take home message, COVID-19 is a global issue threatening millions of people with death and life-threatening complications. Symptoms are flu-like with fever, running nose, headache, and body pain. 80% people recover spontaneously. 15% people may need hospital admission. 4 to 5% may need ICU care. Patient with old age, comorbid conditions like diabetes mellitus, high blood pressure, cardiac disease, kidney disease, stroke, carcinoma are in potential threat of COVID complications. This group of patients need monitoring and follow-up. Post-COVID high blood pressure and DM needs careful attention, especially regarding medications and lifestyle modifications. Hand sanitization, mask, face shield, distance 3 to 6 feet, and avoidance of crowded and confined spaces. Vaccination are the key way to protect from COVID infection. Thank you very much for patient sharing.
Thank you very much, Islam Sensei, for your very informative presentation. And thanks. Yes, please.
And these are the, I'm not sure whether these are right or not. I just took help from Google and I made these slides. I'm not sure if there is I'm sorry and forgive me if something one is misinterpreting, because I left Japan almost 25 years back. So I have forgotten many of the Japanese, and I try my something I want to say at the last, and with the help of Google's and what Google has said, and I just paste and copy it here for you. Thank you very much.
ありがとうございます、久野先生。Thank you very much for your great presentation. And thanks to your presentation, I came to know that I should not depend on the maid, Kajilok, to clean up the my room so, for the moderate exercise. So thank you very much. So, それではありがとうございました、磯野先生。それでは、Q&A セッションの方にですね、参りたいと思います。I would like to move to the Q&A sessions. もしですね、ご質問あられる場合はですね、挙手の方をいただきまして、ご質問いただければと思います。いかがでしょうか。If you have any questions, please raise your hand and please go ahead for your questions. じゃあ、山田さん、どうぞ。
はい。ありがとうございます。I have a question for Ashif Sensei. Sensei, thank you. In this COVID situation, I saw the oxygen shortage issue in Bangladesh news article. I mean that there are some difficulties for getting oxygen cylinders for hospital before. How about future prospect of your hospital in this regard? If you allow me, please let me know. Thank you.
Thank you very much. Yes, during the very severe situation in the peak of the third surge, we had faced some oxygen shortages. But now, if we are talking of metropolitan Dhaka, we have or we can utilize the oxygen concentrators, and with that, sufficient oxygen can be managed. In fact, at our organization, our hospital, the Yamagata Dhaka Friendship General Hospital, even in the peak crisis situation, we could handle a good number of patients, both in our ICU and in our wards through high flow nasal cannula. So I would like to assure you that under the present circumstances, particularly if you make good use of the concentrator, where we are not dependent on the supply chain from the producer, the oxygen management can be satisfactory. Thank you.
Thank you so much for your presentation and the answer. Thank you so much. ありがとうございます。
ありがとうございました。他にご質問あられる方いらっしゃいますでしょうか。では、回答お願いします。
Thank you very much. I have a question to Islam Sensei.
Yes.
Yes, during this 1.5 years, so we are living with Corona, so a lot of pressure or stress due to not going out, not so much exercise, work from home. So our body condition is changed before COVID and after this 1.5 years. So this kind of a stressful life change or increase your patient regarding the hypertension or some other disease, not COVID, like a normal disease is also increasing. How do you think the current 1.5 years like a normal patient increase?
Thank you very much. Thank you very much for your great question. And we, including not only the patients, including we are also in stress because we have to face the patients and we have to deal the patients who is having also COVID positives coming to us directly, and chances of getting infection, and also our family is in stress because we may carry the COVID to home and affect our family as well. So definitely the stress is one of the factor, and also as you have mentioned that we are not moving, or lack of physical activities, and also taking not healthy foods are key factor in developing hypertension and other risk factor or potential risk factor of heart attack. Yes, we are getting not less people having heart attack. Also hypertension patients we are getting quite frequently in our OPD clinic as well. And as I mentioned that my suggestion is できるだけ運動すること、そういうしないといろんな問題出てくるかもしれませんけれども、so what I did, I have my fixed 10,000 steps daily. I'm practicing in my home and working place, and that is mandatory. I'm not going outside, but if I get a long walking space in the working place or at home, it's better to walk as much as possible. And also my advice is not to eat rice. Rice is really very dangerous things because it can increase body weight, and it can increase diabetes, it can increase cholesterol, and at the end a patient might have a heart attack as well. So and it's better to use less rice. I'm not saying that you should not take rice, because the way Bangladeshi peoples are eating, we are taking rice in one plate and then we are putting some curries. So that is not good. So my suggestion is to make once in a day 100-gram rice, and the rest morning and evening you can take a bread, and in between you can take vegetable salad, you can take fish, you can take chicken without skin. So, and also shio, I mean the soy sauce is also should be avoided, because these are not good, and also may increase blood cholesterol, I mean blood pressure as well. Alim bhai is there. So Alim bhai, assalamu alaikum. So I think Kawai-san, I think this is helpful for you what I said. So
thank you very much. So both Bengali and the Japanese likes rice. So
yes,
it's tough for us, but let's try. Thank you very much. Thank you.
ありがとうございます。So I should also avoid kichuri and biryani.
Yes, yes, definitely.
ありがとうございました。
It's the addictive food, you know. You should restrain yourself that I will take small amounts, not big. Small serve is okay. Small serve is okay.
ありがとうございます。そう、シェイク先生。So this is your last question. Will come from シェイク先生。
Oh, okay. Thank you for giving me the chance to ask questions. Thank you very much for a nice presentation from Dr. Asif Mustafa Sensei and Waliul Islam Sensei. Very informative. And many of our patients are also going to Yamagata Hospital as well as Worker Hospital. Thank you very much for taking care of them. Some of them are also Japanese and other nationalities. So I have two questions for Asif Sensei and one question for Waliul Islam Sensei. So I'll start with Asif Sensei. Yeah, you said that you said about steroid injection therapy, dexamethasone for COVID treatment. But Waliul Islam Sensei says that dexamethasone is also a cause of diabetes problem in case of diabetes control. So my question in this regard is, can we start with inhaler steroid? Not starting with is there any option that we can start with the inhaler, steroid inhalation rather than the systemic injection? This is number one question. Number two is you talked about monoclonal antibody, and you said that it is available in some of the centers. So I would like to know if it can be purchased over the counter from the pharmacists. In case for some of our Japanese friends are in the periphery. So is it possible to purchase it and get it from the drugstores? And to Waliul Islam Sensei, I would like to, the Evercare Hospital is a big, large hospital. Many of our Japanese clients have asked whether there is ECMO in Bangladesh. So far I know there is no ECMO. So is there any plan for these large hospitals to install ECMO in the near future? So these are the three questions from my side.
Thank you very much for your question. So, Asif Sensei and Islam Sensei,
Yes.
could you provide responses in concise manner because due to the time limitation? Thank you very much.
Yes. Quick answer. Alimuzzaman Sensei, actually, the role of dexamethasone is to suppress systemic inflammation. In that case, the inhaled corticosteroid will not serve the purpose. So we have to go for a judicious short-term use of dexamethasone. Regarding the monoclonal antibodies, as of now, it is not available over the counter. In fact, it is available in a very few centers, but the supplier has informed us that very soon, in the coming month or two, they will have supplies available, but it must be at a hospital pharmacy, not over the counter. Thank you.
Okay, thank you.
Thank you. Regarding Alimuzzaman Sensei question about the ECMO. ECMO, you know, is very expensive and it's not available in Bangladesh. So definitely it does helps in patients in life-saving cases, especially severe heart failure patients, or cardiogenic shock patients. If you are going for emergency angioplasty, then ECMO can save the life. So it is already in our mind, and we are planning to have it in a near future in our hospital as well. Thank you very much.
Thank you.
Thank you very much for your answers. Thank you very much. So this is the end of the Q&A session. Thank you very much for your cooperation. So, Islam Sensei, could you kindly stop the sharing the screen? Thank you. So, それでは、閉会、以上と、をもちまして、質疑応答の方を終了とさせていただきます。皆様ありがとうございました。それではですね、閉会に際しまして、主催者を代表いたしまして、DACA 日本人会、会長の、加納様より、閉会のご挨拶を頂戴をしたいと存じます。加納会長、どうぞよろしくお願いをいたします。
はい、安藤さんご紹介ありがとうございます。日本人会の会長を務めさせていただいております、加納と申します。平成より山谷講師はじめ、大使館の皆様、DACA 日本人会の、DACA 日本商工会の皆様、DACA 日本人会の会員の皆様には大変お世話になりまして、誠にありがとうございます。また、ご登壇の先生の皆様、この度はお忙しい中、貴重なお話をしていただきまして、誠にありがとうございました。Dr. Ashif and Dr. Islam, thank you so much for your precious information and advice for our life and activity in DACA. Islam Sensei, I also try to not to try to eat so much, drink not so much, with more exercise.
Yeah, that's good. Yeah.
Yeah. Then, 先ほどの石川委員会のご説明、山谷講師様からのご挨拶のように、コロナは数字的には少し安心できる状況にはなっていますが、在留邦人の感染率が 10% 近いというところ、また、DACA での人口当たりの感染者、こちらも比較的高水準ということ、また新たな変異株の懸念など、次の波の可能性も十分にあるということで、引き続き皆さんにも気を引き締めて、感染予防にしなきゃいけないということも感じられたかと思います。また、アシュ先生、イスラム先生からもいただいたお話からは、改めてコロナの怖さ、それから耳の痛いアドバイスもありましたけれども、病気にならないように日々の個々のメンテナンスが重要であること、こちらも再認識させていただきました。またもちろんコロナに感染したり病気になったりしてはいけないんですけども、もし感染したり病気になってしまった場合には、早期のアクションが大事であること、で早期のアクションを取ったら重症化が避けられる可能性があること、またバイパス手術等ですね、こちらの高度な治療も受けられることっていうのが分かったことは、皆さんにも少し安心につながったんじゃないかなと思います。コロナに関しましては、当方もコロナに感染した97人のうちの一人でして、アシフ先生はじめ山形病院の皆さんには大変お世話になったんですが、こちらも早期の段階で適切な処置、入院、投薬、注射点滴などしていただいたことで、重症化を避けられました。もしもの場合も、皆さんも早期のアクションを取っていただくことで、取っていただくことをお勧めしたいと思います。最後に、本日は、DACA 商工会との共催での医療ウェビナーということでしたが、今後も商工会さんと連携しまして、商工会のメンバーの皆様と、日本人会の会員の皆様のために有用な情報提供ができればと思っております。ちょっと若干今日は時間が押してしまいましたけれども、この度は長時間にわたりご参加いただきまして、誠にありがとうございました。
加納会長ご挨拶いただきましてありがとうございました。また、石川医務官、アシフ先生、イスラム先生、本日は大変貴重なお時間いただきましてありがとうございました。Apa nanti kita untuk membaca nanti.僕とバディアルトのネクトのバッチ。では、以上をもちまして、DACA 日本人会、DACA 日本商工会主催のですね、医療ウェビナーの方を終了とさせていただきます。本日は皆様ご参加いただきましてありがとうございました。Thank you very much for joining today's webinar. Apa nanti ongshoni warjo no Thank you very much. アバルデカホーベ。ま
た会いましょう。
ありがとうございました。
はい、どうも失礼します。はい、ありがとうございました。どうも。